Hello and welcome to the ITC 571 project closure. My project was for a dynamic ward list. My name is John Shanks. The dynamic ward list project is what is called a clinical decision support system. This is any system in health information technology which helps health professionals make clinical decisions. This could be a simple thing like a body mass index calculator or a complex medication prescription system. What they do is link health observations with knowledge to influence decisions. They're a major area where artificial intelligence is involved, and this project had nothing to do with artificial intelligence, but it's the way things are headed in the future. There were two major review articles which I found, two major meta-analysis which looked at clinical decision support systems and reviewed them to see whether there were features which showed a successful clinical decision support system, also known as a CDSS. Kawamoto et al., which was probably my favorite meta-analysis, found that there were three factors for success. A CDSS, which is success, will provide decision support as a part of normal workflow, so it'll be integrated into a clinician's normal work. The CDSS will provide recommendations, not just assessments. So an example would be if you had a pathology system, this might just say a patient has renal failure, but it won't say why or what to do about it. So a CDSS which is successful will say this patient's in renal failure because they're on this medication, you should change this medication. Another factor for success is those which provide support at the time of decision making. So that's important for it to flag for a review at the time when people make the decision. Second meta-analysis reviewed 162 CDSSs. They found that the ones which were evaluated by their own developers were more likely to succeed, and this is purely because of publication bias. You don't publish data about your failed attempts at a CDSS. Those CDSSs which provided recommendations rather than just assessments also featured in this meta-analysis as a key factor for success, and they found that CDSSs which involved both the patients and the decision makers, so they got the patients involved in the decisions, were more likely to succeed. So the project here was to incorporate a set of clinical rules against three major databases which are used at the hospital, which is the patient flow database, the laboratory database, which looks at lab tests, and the medication database, which records all the patient's medications. And combine these into what is the standard ward list for each clinician. So we were doing this with the pharmacy department, and what is done there is each pharmacist at the start of the day will get a paper chart ward list which shows them which patients they need to see for the day. This ward list just says the patient's name, where they're located, why they're in hospital, but it doesn't give any more information. So there's a lot of room for improvement here, which I think a CDSS could really come in and improve patient safety. The way I did this was I linked all the databases together. Because I only had the 12 weeks on this project and it's just a scoping study, I couldn't build a full database, and I ran into a lot of trouble along the way. So I got the pathology database, the medication database, and the patient flow database, and linked them all in an Excel spreadsheet just using macros with Visual Basic for applications. There was then a macro which fired the rules over the reports and found the problem patients, and then it sent the ward lists out as text files. These were then viewed by the pharmacists in a ward list viewer, which is a Java application, which just views the ward lists, and they can update the ward list there and save it back to the database with their comments. The rules which were included, there were 35 in total, but some of the main ones were, say if a patient is on 3 or more drugs which damage their kidneys at the same time, that is a flag for review. Or if they're on a high dose of medication which is cleared by their kidneys and the laboratory database says that their kidney function is not very good, that would flag for review. If they're on an injection which contains high sodium in the medication database, but the laboratory database says that they have high sodium levels, that would flag for review. Same as if they have a significant drug interaction, or if they're on 2 or more powerful blood thinners at the same time, which is quite dangerous. That's a sample of some of the rules. The key point here is they're all very simple rules, but they can have a huge impact. So I don't think you need 4 or 5 or 6 years of training to note these patients and these problems. I think it's easily done by a computer, and it can save some lives potentially. So the issues I came across along the project was the pathology database only had limited access to this through an aging database management system, which only provided PDFs. So I had to work with another member of IT at our institution to convert the PDF files into text and then convert the text files to CSV. We had to work together to make a bespoke application which goes through this flow to change them over to CSV files to import them into the database. The medications database also provided some issues. It gave inaccurate reports, and we could only run a report for the entire Northern Territory rather than individual sites, which is an issue. So then we had to put in some loops to try and find the data which we wanted out of that entire report and import that into the database. And there's also a number of fields which we wanted which we couldn't get, such as patient weight or allergy status. The ward list viewer is a very basic database management system just built in Java. It just imports text files into a JTable. The user can modify that and then resave that JTable as a text file again. Work's still underway to improve the formatting and permissions so that clinicians can read and write whilst the database is running updates, but more to be done in that space. So to evaluate this, I've just put in an ethics application and I'm just waiting to get it back. Unfortunately, I've run out of time, but the plan is to look at all patients who've got an uneven patient reference number. That's just the reference number they get when they're in hospital, and to get the system to only show hints for the ones with an uneven reference number. Anyone with an even reference number will not show hints. Then I will ask the pharmacist to jot down all the interventions they do over a week-long period and see whether the ones which are uneven have more interventions applied to them rather than the ones who are even. This will also help because I'll be able to note any rules which I could add to the database from interventions people are doing, and I can find the rules which are flagging inappropriately. After the scoping study, I'm hoping to get unrestricted access to the medication and pathology databases, and to build a dedicated database to combine all this patient data rather than just an Excel hack database. That'll help to improve workflow and improve the stability of the system if it shows that it's successful. Thank you. Please email john.shanks@nt.gov.au if you have any questions about the project.